Dear colleagues, welcome to this new module of ESOU Online. My name is Rouprêt. I'm the chair of the section of onco-urology. I'm surrounded today by three guests. We have Professor Alexandre Taille from Paris. Thank you for being there. You will give a lecture on metastatic hormone-sensitive prostate cancer. We have Juan Gomez Rivas from Madrid. Thank you for being there. You are the chair of the Young Academic Urologist, and we will discuss with you a clinical case. And we have a lady, a medical oncologist, Efstathiou from United States of America. We will look into the future and what is next in the pipeline of prostate cancer. So without transition, I go back to you, Alexandre, and I thank you. There is a big, I would say, a breakdown in the paradigm of treating prostate cancer. And recently at the ASCO GU, we have discussed a lot of data. So I think that there is room for intensification of treatment of metastatic hormone-sensitive prostate cancer. Can you let us know what we learned from the ARASENS trial?
Well, ARASENS Trial is going to change clearly our practice in the near future, and I'm happy to be with you and to share this slide with you about this ARASENS Trial. So as you know, darolutamide is used as an androgen receptor inhibitor. It has a strong efficacy, and is in this phase 3 ARASENS study, we look at the fact that perhaps darolutamide plus docetaxel plus ADT will improve the survival of the patient compared to placebo plus ADT plus docetaxel. So this is what we call the triplet, and we are going to see the results. So this prospective randomized trial, phase 3, was launched in 83 countries, including a lot of patients. The patients were selected as metastatic hormone sensitive with ECOG performance status of 0 or 1, and were candidate to this association of androgen deprivation and docetaxel. And we stratify the result with the extent of the disease and also about the level of alkaline phosphatase that we have in blood. So the endpoint is clearly a very important point because it's an overall survival, but we have also some secondary endpoint like the time to castration resistance, time to pain progression, and so on. The classical, I will say, endpoint that we have in this kind of study. So as you can see on the slide, we have now the baseline characteristic of the patients that are well balanced in the different groups. I won't go into the detail. I want to go directly to the result. That is really important because it's an overall survival of the association of darolutamide plus androgen deprivation plus docetaxel that you see clearly is better than placebo plus androgen deprivation plus docetaxel in M1B prostate cancer patient and in M1C prostate cancer patient. So we are looking at the level of importance of the disease. You know that M1B, it's a patient who have bone metastases and some lymph node metastases, and M1C is really patient who have visceral metastases. That is a strong risk predictor of poor prognosis.
So from these slides, I think that I was talking about intensification. We can say today, for sure, from the guidelines, national guidelines, European guidelines, that androgen deprivation alone, as we knew it, is not sufficient. The combo is there. But
Absolutely.
From this study, it means that in high-volume patient, high-risk patient, maybe it's a triplet that we should consider. So there is still room for chemotherapy.
Yes, this is an important point. We have the PIS1 study who already tell us that docetaxel plus abiraterone is better than abiraterone alone. And we have now a strong evidence that combining chemotherapy and new androgen deprivation plus normal androgen deprivation is better than docetaxel and ADT. So, as you said, probably the guideline will publish next year or in 2 years that docetaxel alone is not recommended for this kind of patient. Okay. So we move on with the level of alkaline phosphatase, again, under the normal level or above the normal level. And again, for the use of darolutamide and docetaxel is better to placebo and docetaxel. So again, this is another endpoint, time to castration-resistant prostate cancer. And without any surprise, we have the same result. And we have, again, longer time to castration-resistant prostate cancer when you use a triplet compared to just a combo. So this was the severity of the side effect. And again, we didn't see a major difference by adding darolutamide to ADT for all the side effects that we have. So in conclusion, in patients with metastatic hormone-sensitive prostate cancer, darolutamide in combination with ADT and docetaxel significantly increase overall survival and delay time to castration-resistant prostate cancer compared to standard of care ADT and docetaxel. And we saw this conclusion and this endpoint for the overall patient, but also for patients who has a very unfavorable profile.
So I think it's important for our colleagues to bear in mind that so-called classical androgen deprivation, what we call ADT, is still there. It's still the pillar of the treatment of prostate cancer, so LH-RH agonist or antagonist. On top of that, we need to add the new generation of androgen deprivation, the HTNG. We can consider today 3 drugs that are available in Europe: Daro, enzalutamide, and you said abiraterone. And so it's absolutely important today to know how we will use and incorporate in our practice the TEP imaging and the molecular imaging in these patients. Because all these studies, and especially ARASENS, which, as you mentioned, cannot be criticized in terms of methodology, used, I would say, old-fashioned criteria to include the patient. So how can we translate this data in our practice now? Because we try to expand the use of molecular imaging.
Well, probably with this new imaging, we have a diagnosis of metastatic prostate cancer with a lot of bone metastasis or visceral metastasis, going perhaps to help us to push the patient in a certain direction at time of treatment. But again, when you look at the guideline, there is no modification of the guideline by using this kind of molecular imaging for the moment.
So going back to the guidelines, yeah, we were discussing the drugs. It's APA, Daro, Enza, and Abi. We are 4. Okay, thank you for this presentation. So we'll move forward into the program of the module and go back to you, Juan, because I think it's time to open the discussion around a very pragmatic clinical case. And we will discuss with you on the options that are available for the patient. Thank you.
Thank you. Well, thank you for the opportunity for being here today. And we're going to try to translate what we know from the clinical trials into real-world data or real-world cases, let's say. And why is this? Because sometimes we see some gaps between what is a control setting, what we see in the randomized control trials, and what we see in the real world. Sometimes the patient that we have in front of us in the desk is nothing compared to what we see in the trials. So this is our case study. It's a 70-year male patient, no allergies, hypertension, treated with enalapril, no oncological background, no familiar oncological background. He had a bilateral hernia repair. The first time he came to clinics in 2016, let's keep this in mind. This was 6 or 7 years ago. We have seen that landscape of prostate cancer treatment has changed completely. But in 2026, he came to lower urinary tract symptoms with a pathological diarrhea and a PSA at diagnosis of 113. This is the biopsy data and metastasis assessment. He has an adenocarcinoma of the prostate, Gleason 9, 8-12 course in both sides. He has a CT scan with a lymph node enlargement of 12 millimeters in the short axis at the right external iliac region and no bone metastasis. So the final, let's say, assessment of this patient is a adenocarcinoma of the prostate, Gleason 9, C3, CN1, M0. Depending on the classification we use, it can be high risk, very high risk, or localized but advanced disease. He underwent ADT in that time with beta-glutamide, ADT, normal ADT with analogous plus beta-glutamide. And he, after 2 months of treatments, his PSA dropped to 0.4 and with a testosterone in range of castration. So the first round is based on that we have some well, some know, we have a clear definition on low risk, intermediate, and high risk prostate cancer based on PSA, Gleason, and T-score. But this was done probably in the 90s or the early 20s. So now we probably need new tools to define high-risk prostate cancer, because in this big box of high risk, we can have many different kind of patients. So the question to debate is, what tools do we have in order to know which prostate cancer is the cat and which prostate cancer is the lion?
So the thing is that back in 2016, when you treated this patient and was diagnosed in your office, the pre-treatment workup was based on CT and bone scan. Am I right?
Yes.
But if you consider the situation in 2022, actually the guidelines are still sticking to this, I would say, pre-treatment workup investigation. So there is no big change. And actually you mentioned a change, but the change is on the drugs that are available on the table. So maybe today we would have initiated the treatment otherwise, sticking to the presentation that Professor de la Taille has done a few minutes ago. But if we stick to the guidelines, we will do bone CT and I would say abdominal CT. I don't think, as far as I am concerned, that it is enough. And especially in this patient who is quite young, I would fight to get a TEP imaging, because I think it will change the stratification you are trying to make. And it will influence the decision to treat the patient with a combo, a duo, or a triplet. So today, it's just a question of getting an imaging that is going to influence the decisions. Not getting an imaging to have images, but if it is going to change your decision at the tumor board, then I think it's meaningful. What is your point of view, Alexandre?
Yes, again, it's the same question that we had a couple of minutes ago about my case and the metastatic hormone-sensitive prostate cancer. If we want to find metastasis, you will find. The problem is a question of cost. It's a problem of reimbursement and problem of accessibility. So for this patient, if you go to a PET imaging, probably you will find something. But is this really going to change your practice? Are you going to change the treatment? Are you going to do something else? This is again questionable. And again, in the recommendation, there is nothing on that.
Yes, and once again, going back to the recommendation, it's fascinating to see how many new drugs we have, but how we did not change the way we treat the patient according to the guidelines itself. So if we want to change the guidelines, we are also to enroll patients not only in drug trials, but I would say in evaluation trials of this patient. And there is also the question of the availability of the TEP imaging, because in our country, TEP PSMA is quite difficult to access. How it goes in Spain, for instance?
In Spain, the availability of PSMA is limited to some centers. It's not widely spread. Where I have concerns now with the PSMA in the stratification setting, let's say that it's probably we don't know the impact of this treatment changing. We don't know if this treatment changing will have a translation in the future in overall survival. This is difficult to know with the data that we have nowadays. And the second thing regarding PSMA, this is something that also concerns me, is the overtreatment. If we are looking at the same disease with two different imaging, it's the same disease. But one is with an advanced, let's say, imaging, which is PSMA, and the other is like an old-fashioned way, but it's the same disease. So leading to the diagnosis of metastasis or lymph node will probably become an overtreatment of a disease. This is a personal thought. I don't know what you think about it.
Yeah, seriously, I completely agree with you. I will see. Well, all of this question of imaging is, are we going to change our treatment? And this patient has high-risk prostate cancer. I'm going to ask you the question, if you do a PET PSMA and you find 2 or 3 spots on bone, are you going to change the treatment?
That's the $1 million question. Yeah, that's the $1 million question.
Translating the case of this patient from 2016 to 2022, for sure the blockade would have been different. You meant triptorelin, we keep it, but on top of that, for sure, we had APA, DARO, ENZA, or ABI. That's for sure. And this is the standard today. So monotherapy cannot be an option. And the question of chemo is based on the rationale, the local experience, would say, and maybe the availability of the tape imaging. But we have to discuss with also this with medical oncologists. Let's move on with your case.
So this was related to what have probably we have been discussed today. What would be the options to these patients? This is already covered. And the question number 2, what would be your treatment options today for this patient?
So we mentioned already that we would change the type of androgen deprivation by systematic intensification. Androgen deprivation plus one of the new kids of the block that we mentioned already. One question that, as urologists, we didn't discuss is that the prostate was quite big in a 70-year-old man. And so do we consider also the probability of local treatment, I would say, if he has urinary symptoms? Or do we believe that the androgen deprivation will impact favorably the urinary symptoms? What do you see in your experience, Alex?
Well, I think in this kind of patients, we have to go for a local treatment, for sure. Either radiation therapy with hormonal therapy. For surgery, it's an N1 disease. Perhaps it can be included in the Proteus trial. This can be discussed.
You mean with neoadjuvant?
Yes, including ADT plus new hormonal
treatment?
Agents. Yeah.
Before surgery?
Before surgery.
So there is also, and as you mentioned, the standard. And I think that we as urologists are more keen to recruit patients in clinical trials. Not only because it's a change of philosophy and the way we treat the patient, but also because the pharma company understood that we are recruiting this patient in our daily practice, and they should stick to our practice to open more options for our patients. And one solution for this patient is to have the possibility to enter a trial.
Probably nowadays for this patient, the standard of care will be and this is stated in the guidelines, radiotherapy plus ADT plus ABI 2 years, as is localized with high-risk features, let's say. It depends if we migrate this to oligometastatic disease with a PSMA. But for what we have with a CT and only a bone scan, it's localized high risk, let's say. Okay, so let's keep on the case. The patient started ADT. His PSA was low, 0.4, but the patient underwent another CT scan and seems there is response. That large lymph node that the patient had now is below 1 centimeter, and it was presented in the tumor board. And in that time, they said, okay, now we have N0, and let's do some local treatment to the prostate in 2017. So the next question is related to what is the role for each of this in the high-risk localized prostate cancer. What's the role of radiation? What's the role of surgery? And what's the role of systemic treatment?
I think there is always we had the opportunity in centers in Paris to carry a clinical case through different medical boards, tumor boards discussion, and people were blind from the previous discussion from the other tumor boards. Only the head of department was aware that it was a ghost case, I would say. And there was a huge influence of the local habits on the regimen of treatment which was chosen to the patient. So we foresee from the beginning that in that center he would have received radiation, and in that center he would have received surgery. I'm not so sure that today we are in a situation or in a position to make a full statement to say this guy is a good candidate for surgery or he should undergo radiation. I'm just saying that all the options are on the table, and it's typically the case where the case-by-case discussion is fruitful for the patient, because we are a bit in the blurred lines or the blurred limits of the guidelines. You know what I mean? And so I believe we have to be open-minded and to be on an open-minded exchange with a radiation oncologist.
Absolutely, absolutely. This case has to be discussed in tumor board, and there is two options. Either going for radiation therapy and hormonal therapy, and probably long-term hormonal therapy, including new hormonal agent, or discuss, if it's possible, inclusion in the Proteus trial to compare the use of hormonal therapy for 6 months before surgery and 6 months after surgery of, again, hormonal therapy.
So for the role of local treatments, nobody can say with a strong, I would say, opinion now, because the data compared to what we know in systemic treatment and metastatic disease are very low quality. It would be a bit subjective or irrational to say, look, we had as strong data in the local treatment modalities that we have in the systemic treatment. But for sure, we do believe that when we have an aggressive disease in a quite young patient, then you will have to have an aggressive behavior against the disease, I would say. And I would stick to this philosophy now.
I'm fully agree. Probably what we need to have in mind is that probably a localized advanced disease is not equals to systemic treatment.
Yes.
Local treatment can have some role, of course, discussing before in a tumor board. So this is the follow-up of the patient. As you might see, he has a good PSA response during many years. And in 2021, his PSA started to rise. And based on PSA doubling time, he has a doubling time of 4 months. A new CT scan was done, and there was no significant change between this CT scan and the one that was done previously. And then, finally, a new CT scan was done in May, and there's suspicions of have some metastasis in the lung. With this suspicion, a PSMA PET was done in 2021.
Okay.
And PSMA PET reveals deposit in pulmonary node in anterior segment of the superior right lobe, 15 millimeters, with no enlarged lymph nodes in the abdomen or pelvis. So, is this a criteria of castration-resistant prostate cancer? Would be the first question, because by the time the PSA is not over 2, but he has progression in the imaging.
Yeah, but you have to look at the testosterone level as you mentioned it, and I think if we stick to the definition, we can see that it fits in this box, because there is a long history from 2016-2021, so with a good response, and then a low testosterone level, low PSA. The situation is evolving, and I want the colleagues who are listening to us to bear in mind that at this stage of the disease, not only the PSA is a criteria of judgment, but the evolution of the images. And I think it's quite important to see that, I would say, it fits in the criteria, and we need to change a little bit or to rethink the treatment.
That's a very good point. I think we have to take into account into the definition of castration-resistant prostate cancer, also the imaging. There was a poster presented in ASCO where we saw that there in some patients is imaging progression without PSA progression. And this is important to have in mind. So the case was all, again, presented in the tumor board, and we decided to do genetic testing, change the treatment to ABI plus denosumab. This is the current landscape of prostate cancer, advanced prostate cancer treatment. It's quite a mess, but we need to figure out where to place each treatment in the different stage of the disease. So that's the final question. With all the options that we have, what tools we might manage to select the best treatment for our patients in advanced prostate cancer?
Well, I think this guy is back to the future. It's 2016, and now he's sticking with the new modalities of treatment. So he will start his disease today. We will have done it otherwise. Anyway, he's evolving with the recent data. So the tools is probably the clinical data that we get for from the big conferences. The tools are, I would say, the evolution in the pre-treatment workup, which is obviously the TEP imaging. Should we do it from the beginning for the stratification of the disease, or only in case of recurrence? These are, I would say, unanswered questions in the field. And on top of that, you mentioned the genetic testing, because besides the new androgen deprivation molecule, we have the PARP inhibitor. And I think we should be aware that even if the patient does not belong to a family where they carry an hereditary mutation, the tumor itself can express a mutation. It's the difference between germinal DNA and tumoral DNA. So there is room to search for this patient and the possibility maybe to prescribe and to do personalized medicine in that setting. So the tools are imaging, clinical experience, and genetic testing potentially, but not in all cases because the cost is also a problem. What's your opinion?
Well, yes, totally agree. We know that we can find some gene mutation in 20% of this patient. And for this patient, PARP inhibitor will be an interesting option. Yeah.
I think we need to close.
Yeah.
Yes, this is the final outcome of the case, negative for genetic testing. And nowadays, the patient has an undetectable PSA with testosterone in range of castration.
Perfect. Thank you for this nice opportunity to discuss. It's a way to demonstrate how much we need the input also of the medical oncologists. And this is the reason why we asked Eleni Efstathiou to come today and to discuss the medical oncologist's point of view when it comes to the choice between doublet or triplets, because the intensification in their culture can be different towards prostate cancer. Thank you very much.
If we want to prove a point, I think we've already done it, of whether we should be including enhanced androgen signaling inhibition. I'm very cautious about not using the word novel anymore, since these agents are becoming or have already become generic in parts of the world and hence are accessible to everyone. So my disclosures again. And I will start in the same fashion, but I will stop at 2020. It's almost like a pre-pandemic and a post-pandemic, and try to explain, at least in my view, how this whole triplet story came about and how we're stuck with it from one-sided perspective. So this is the therapy evolution, as we said. And if this was sports, yeah, by the way, because of COVID, I was grounded and I got to watch a lot of US football. So if this was sports, ADT plus docetaxel versus ADT is 2-1, right? There were 3 trials, 2 positive. And then if it was ADT plus androgen receptor inhibition of the new generation versus ADT back in 2020, he was 5-0. So I guess we know who's the winner. We also knew by 2020, because we were looking at the data and we were looking at meta-analysis, that from both a failure-free survival and an overall survival, there is no question that a doublet was better than ADT alone. So as we used to say before the pandemic, don't overthink it, just do it already. Just add Abi or Enza, or later on came apalutamide. We didn't have data on darolutamide, or give chemo if that's what you've got. Just do it because you're going to add survival to your patient. Interestingly enough, the use of chemotherapy in the United States shrunk tremendously over the past 5 years, and that of course has to do with the pandemic, but also with the change in practices to being less than 10% currently in this disease state. But one could see the writing on the wall, right? Earlier androgen signal inhibition treatment seems better. We could see the stage-related incremental change in survival delta with the inclusion of ASIs. And I have put there latitude, even though it's a poor risk trial, to show the difference from using these inhibitors in the advanced disease, where you got a delta in survival about 4.5 months. And this is all relative, but you're looking at a different magnitude of order. You're looking at 1.5 years of difference in survival. And you can come at me and say, well, that's because patients were not subsequently given the other agents. Well, yeah, what comes first is the most important, obviously. This is real world practice. And again, as I mentioned earlier, you cannot debate 16 positive trials and no negative trials, none to this date, even though there was an opportunity since we're accumulating these agents later, right? And of course, Chris is here. If I recall correctly, Chris, you always wanted to do a high volume trial, but you had to adjust to include everyone. And if you look, even though people criticize sometimes this analysis, if you look at their more recent clinical analysis, the low volume metastatic hormone-naive prostate cancer does not derive as much benefit from docetaxel. The man said it earlier himself. So back in 2020, we had these key messages: doublet combination with either enhanced androgen signaling inhibition or docetaxel is a requirement for the vast majority of metastatic hormone-naive prostate cancer with appropriate monitoring. And bear with me, it looked like we were actually overacting sometimes, again, erring on the side of caution. But the writing, as I said, was on the wall suggesting that addition of enhanced androgen signaling inhibition is likely the preferred choice for reasons that have been discussed. And of course, message 3 back then was, do not delay, start a diagnosis. So what happened through the years? Well, the next question, which was in the making since 2015, is more better. But why was this question in the making? Because first we got the data over docetaxel. So that, for a brief period of time, for 2 to 3 years, became our standard of care. And if you recall these times, the uptake was not as uniform. The pressure for inclusion was not as evident as it is obviously now. But arguably, every trial that would start in that period of time needed to include that standard of care. That was the ethical thing to do, which leads us to triplet time. So, as Karim Fizazi presented this to us, it was indeed that situation. Look at the accrual, November 2013, December 2018. As time was progressing, they had to adjust. That was the right thing to do. The evolving paradigm that was close to practice. So their standard of care included both ADT alone, but the ones later on were ADT plus docetaxel for the most part, and especially the high volumes, right, enriched. The data for some may have been construed as triplet versus doublet. For a lot of us, is construed as, oh well, androgen signaling inhibition does it again. No matter what you're using, adding on abiraterone makes the difference. And it's not fully mature for low volume, obviously, but you can already see it in survival for high volume. It doesn't matter what's your standard of care. What matters is the addition of abiraterone. And of course, this was, as a lot of people say, quite convoluted a trial. But then we go to the most recent data with ARASENS, which is a clear, granular trial that is looking at a standard of care again, docetaxel plus ADT, adding on darolutamide in this case, or not. Let me point out, because I did not include in this trial, but it came to my attention, that both arms had 4% toxic deaths. Both arms. So it wasn't darolutamide driven, right? It was docetaxel driven. Not saying that necessarily docetaxel is a bad thing, but if you're going to use it, you'd better be careful. And the data proves without a doubt that, again, the addition of an enhanced androgen signaling inhibitor makes a difference, and more obviously to come. So in short, now this is, I'm hoping, the post-COVID, I'm using loosely the word, times where we've added the triplets. But did we? All we did was just reinforce what we need before. Standard of care, whatever that was, plus addition of an enhanced androgen signaling inhibitor, 7-0. So, monotherapy today in 2022 with ADT is unethical for your regular guy, right? I'm not talking for your ejection fraction 20% kind of patient. Doublets. ADT plus enhanced androgen signaling inhibition is a requirement, whereas all of a sudden ADT plus docetaxel alone is not that much of an acceptable choice based on these two last trials we saw. And when it comes to triplets, ADT plus docetaxel plus enhanced androgen signaling inhibition is not a requirement, but it is a choice under certain circumstances. And that's why my title was more about requirements and choices. Again, the main take-home message is one: enhanced androgen signaling inhibition is a requirement for these men. Thank you very much.
Thank you, Eleni, for this excellent overview. Every good thing has to come to an end, and this is the end of this new module of ESOU Online dedicated to prostate cancer. Please let us know by feedback, email, social media, how you like this module of ESOU Online on the uro-onco platform, and do not hesitate to communicate with all the tools of the European Association of Urology. Thank you very much.